Okay, so we're gonna do neurologic disorders and drugs. So this is the first of 3 units that are going to be on your last exam before the final. Um, on to get this. So I just sent out, I'm not going to mess with it, but if you go into Moodle, if you scroll down to week 13, I opened up a study guide that was there from last year. And sometimes I shift weeks slightly, and so I can't use the exact exam that I necessarily used the year before. And so that's kind of what happened with the study guide for this exam number 2. And it's the same with the study guide that is there for exam number 3. It's all pretty much the content that I would want you to know, except for at the very bottom, it talks, I think, about like HIV and stuff, and that's not going to be on your exam 3. So that study guide, if you want to look ahead, it is useful. There's tons of stuff on there that would help prepare you for exam number 3 if you want to study ahead or just kind of get familiar with some of the stuff. But some of it is not going to be on the exam, but mostly just that last section that is like HIV. And then the other thing that I put in there was the last worksheet, number 5, and that's going to be over what we talk about today. So if you like to work ahead, you could get the worksheet done early, or if you just kind of wait until it's due, it'll kind of force you to come back to this week because it'll be, like a couple weeks now until, you'll have a vacation in between, but it'll kind of make you go back to this content and review it before exam number 3. So that's why I made the last worksheet on this content. So however you want to do it, it's fine. You can turn it in whenever, but it will give you a chance to review it before the exam. And then I know what I did want to do. Shoot. Okay. I do have to come out of here for just a second. I do have to pull up Moodle because I did want to show you guys one thing. Okay, I'll put it over here. Okay, so where the case number 2 is down here somewhere. Case assignment. Thank you. Case study assignment number 2. So there's the submission. I don't know if anybody has submitted it yet. One person did it. So this is the actual assignment. And I did want to just call your attention to so there is a rubric, and notice the points. I hope I made these make sense. I thought I double checked my rubric. Hopefully I might have to triple check it. But notice it's a pretty tiny point margin in order to like pass it. And I want everyone to get all 25 points. Like my desire is that everybody will get all 25 points because it's kind of like a little bit of a built-in cushion for a class that has hard exams. And so my anticipation is not that I get to be nitpicky and deduct points. I really want to just give you all the points. That being said, please give me thoughtful answers. If you just write like a sentence or two, I'm going to be hard pressed to want to give you full credit. So I tried to give an example. Now that doesn't mean you have to like write a novel, because I also don't want to read 32 novels. But I just want an example that I can tell that you actually thought about it, tried to think about it in a holistic way, in the way that you would have to approach anything for full patient care. I just don't want it's like brief answers. So I try and give an example. So a question here. So what would you recommend for this patient to help her avoid developing caries? That's a really straightforward question. Someone might be like, oh, I would say don't sip on sugary drinks all day, don't snack, brush twice a day, floss, use fluoride. I wouldn't call that a very good answer. Is it a wrong answer? No, it's totally not wrong. It just doesn't tell me that like you thought about it more than you just tried to recall like a few things. So I just give an example here of the kind of thing. Now, something like this, what's your patient? Here's another. I'll give you another example just because you might be like, how do I know what she wants? So, what is your patient's overall ASA? You could totally just put two, but just support your answer. I would put this patient at an ASA, a two for their ASA due to the following things. So that's all I'm basically trying to say is give me a little bit of support with your answer, so that I know that you really thought about it and you're not just trying to like get through it and give as short of an answer as possible. You're always welcome to send it into me to proofread ahead of time, but I just wanted to kind of make that point clear. And if you guys have any other questions, there's 11 questions, and it asks for 3 references in APA. It's easy if you're not real good with APA, just stick it into Chat GPT and say, "Can you make this APA style citation?" And it'll kick it right back at you. So it's easy to get citations in the style that is being requested. And then here's the case doc. Do you guys have any questions about that at all? That's pretty straightforward, huh? Okay. Was that a quick? No, you're okay. Yes, this is not until it's not due until week 12. Okay. So this is not due for the end of the first week. No, yeah, it's due at the end of the first week after you get back from break. So you could do it over break. I don't want you to work over break. I want you to actually have a break after break. So you could, you start it now, finish it later. I don't think it'll take you more than like an evening, like an hour in the evening. I mean, so it shouldn't take you a super long time to do the assignment. But yeah, it's not due until after spring break, week 12. Okay. Now we'll just get back to this here. Okay, so neurological disorders and drugs. We're basically gonna just talk about 3 conditions. There's obviously lots of different, we don't even talk, and every year I think, oh, I should probably talk about medications that maybe are used for like, used in autism or in ADHD or something like that. But it's just hard to keep adding medications because there's already so many. So I picked, or whoever writes the textbook kind of picks big categories of some major conditions. So seizures and epilepsy, Parkinson's disease, and Alzheimer's are 3 sort of major conditions that are neurologically connected. So we're going to review the key functions of the neurotransmitter. So there's a little bit of review in this section, which is nice. Discuss pathophysiology, signs and symptoms, and treatment for these 3 conditions. Identify different types of epilepsies. Hopefully some of that's also kind of reviewed because you had medical emergencies, probably discuss a similar thing. Discuss neuropathic pain, and some of the related medications like gabapentin that can be used for other things besides neuropathic pain. But that's one of the main reasons that medication. So this is a summary of the medications in this unit. So it's just a summary slide. These are different medications used in Parkinson's. Again, it's not exhaustive. There are other Parkinson's medications, but these are just a sampling in the category. There's not a lot of medications that they use for Alzheimer's, and I think there's a new one. I don't think that one of these is the new one. I think these have been around, but I could be wrong. But there's not a lot of drugs to treat Alzheimer's. And then seizure medications, and then neuropathic pain. So those are the meds that we're going to cover for this unit. So then the nervous system, just you guys probably remember this, central nervous system is our brain, spinal cord, and then we have the periphery or the peripheral nervous system, everything that branches off going out our extremities. And then that's further divided into somatic or autonomic. Somatic is like, I'm going to move my arm up and down. And then autonomic is my heart's beating, thank goodness. And then autonomic nervous system is divided into the sympathetic and the parasympathetic. So that's just that quick review of what we've talked about in the first week or second week, I guess. Okay, so then how one neuron communicates with another, chemical signals are sent down the preganglionic neuron from the central nervous system. That's an action potential is sent down, and then it releases neurotransmitters down in that synaptic cleft in between the ganglion, the pre and post ganglion, and so those neurotransmitters are basically like the communication element, chemical substances, and they get released. They go on to the postganglionic. They keep that action potential going, sending that message until it gets to the target organ. So whatever it's going to be talking to, whether it's the heart or eyes or stomach or intestines or whatever it is. Um, so more review for neurotransmitters, the actual chemicals, they are synthesized in the neurons and they're stored in these little vesicles or little sacs located in the axon terminal, so down at the ends there of those neurons. Neurotransmitters are released in response to an action potential, and then they bind, those are the little messengers that bind to different receptors. And so when we have drugs come into play, they either take up those receptors to prevent the neurotransmitters, or they kind of stimulate the event and have it happen more, whatever is supposed to happen at that target. They create a new action potential with the release of more neurotransmitters that bind to receptors on the target organ. And then the result is we have kind of some new words in this unit: inhibitory or excitatory or excitability. So inhibitory is kind of like, just like it sounds, kind of calming or reducing of some kind of an action. And then excitability, kind of stimulating or stimulates some kind of an action, creates it more in an organ. So for inhibitory, it blocks or prevents the chemical message from being passed along any further. And then excitatory or excites the neuron and causes it to fire off the message. And you can see in this little figure here, a few of these are going to be familiar because we've already talked about acetylcholine and norepinephrine. And I think no, we haven't talked about any of the others, but they're in these categories. So if it's a neurotransmitter that tends to be more of an excitatory neurotransmitter, then we're going to be referring to neurotransmitters such as glutamate, aspartate, and nitric oxide. Glutamate, we do talk about in this unit, but the other two we don't. So these are just examples. You don't necessarily have to memorize this figure. These are just examples. And then for inhibitory, glycine, GABA, we do talk about GABA today. Serotonin, we talk about in another unit, and we do talk about dopamine today. So those are examples of inhibitory neurotransmitters. And then neurotransmitters that can either act excitatory or inhibitory, but just depending on the circumstance, is acetylcholine and norepinephrine. And we've talked about those in the past. Okay, so what neurotransmitters are we familiar with up to this point? Basically, we've talked about acetylcholine, norepinephrine, epinephrine, and then a few extra ones. And this is not totally all of them that we're going to talk about today, but for the most part, I think these are the main ones. We're going to cover dopamine, glutamate, and GABA and how they interact with these diseases processes that we're going to cover in this unit. So we're adding those to our list of neurotransmitters. So this, I'm not going to play it just because there's a couple other videos in this PowerPoint that I think are probably worth playing. This one just basically shows a neurotransmitter traveling down the neuron, being released, going and attaching onto some receptors. And I like the video, it's short, but I'll let you guys watch that on your own time. Okay, so there's a star here, so there's probably going to be information off of this slide that, is on an exam. So when we talk about some neurotransmitters and what they do in the body, we have dopamine, and everyone's heard of dopamine because we kind of think about it as like the feel good, right? Like one of the feel good neurotransmitters. So, but it's also a significant neurotransmitter in the process of movement, which we probably don't think of that as readily. So dopamine, you want to think about movement, and we'll think about that in how it relates to the diseases that Parkinson's specifically. And then we have acetylcholine, which we've talked a lot about in the autonomic nervous system section. But now we're going to think about more about what acetylcholine does in the body under certain circumstances. So in the peripheral nervous system, acetylcholine is involved in skeletal muscle movement and regulation of smooth muscle and cardiac muscle. So those are kind of the areas, and I highlighted in purple the skeletal muscle movement to help you remember how it relates to the diseases that we'll get to. So in the central nervous system, the brain and spinal cord, acetylcholine is important and involved in learning and memory and mood. So just looking at this slide with acetylcholine, the purple skeletal muscle movement, and then acetylcholine, the purple learning and memory, we can already kind of, and if we know Parkinson's, if you have any familiarity about what Parkinson's at all, it's a kind of a heavily movement disorder. Like you can tell the person has all kinds of issues with movement. And then Alzheimer's is obviously like a dementia. There's a lot of issues around learning and memory and that sort of thing. So we can already sort of anticipate that acetylcholine is going to play different roles in those different conditions. So for balance, posture, involuntary muscle movement, acetylcholine is excitatory. So it plays an excitatory role for those kind of movement. And then dopamine is more inhibitory. But everything sort of in health, in a healthy body, everything sort of is in balance. It's in equilibrium. You have just the right amount of this and just the right amount of that. So it's kind of like when we were talking about the thyroid condition and how there's that negative feedback loop, and your body triggers the release of more hormone when it's like, oh, I need more. So everything kind of functions in this nice balance, equilibrium. And then when disease happens, the balance is off. And that's true for almost everything. So for acetylcholine is excitatory and dopamine is inhibitory, and they function in this equilibrium when it comes to muscle movement. If dopamine is absent, so if dopamine's being broken down too fast, or if dopamine's not being created fast enough or in decent enough quantities, then the acetylcholine can kind of stimulate and produce more, and now you have an imbalance. Now you have probably more acetylcholine than we should have and not enough dopamine. So it's kind of just an example of how this can take place in a disease condition. So then we have the other two neurotransmitters that we're going to cover. GABA, gamma aminobutyric acid. It's inhibitory in the presynaptic neuron. It's release. That's where it releases in the neurotransmitter in the presynaptic neuron. I'm like losing my words. And then glutamate is excitatory. Now, does anybody know what MSG is? Most people know monosodium glutamate. So it's such a weird thing, and I don't even know totally how it relates, but I just always heard my mom would tell me this. She's like, don't eat MSG. It's neurotoxic. It's like it's a neurotoxin, and it excites. She would tell me this, and she learned it from some health guru. And then when and I was like, okay, I'll try to avoid MSG, Mom, thanks. And but that's always helps me remember the glutamate, and that it's excitatory because of that thing that she would tell me. And I don't know exactly how it relates. Obviously, monosodium glutamate is something that you can add to food, but it's also something that's naturally occurring. It just it's like made when proteins are broken down in the cooking process of some way. I don't know. It's something that happens anyways. But that's just one trick that I've used to try to remember that glutamate is excitatory, because I think of MSG. So, a major mediator of excitatory signals, it involved in normal brain function. It helps with cognition, memory, and learning. However, it can work only on cells with a glutamate receptor, um, or a glutamate receiver, but it can be toxic in excessive amounts. So now if we have an imbalance and there is excessive glutamate, maybe not enough GABA, then we're going to have an imbalance and it's going to have an effect on this cognition, memory, and learning because it can be toxic in excessive amounts. So that's sort of the background of the neurotransmitters that we're going to cover in this unit. And now we'll kind of see in a little bit more detail how they play into these diseases. So for Alzheimer's, it's age related. Most of the time, you're going to have somebody that's older, 65 plus, that has Alzheimer's. There are people that have developed early onset Alzheimer's. I actually had a patient who had teenage kids when I worked here in Hillsborough. He was like in his 50s and he had very rapidly developing Alzheimer's and he had teenage kids. It was really sad. But it's much more common in older individuals. And it is a progressive, so that means it gets worse. It progresses as the disease goes on. Neurodegenerative disease. So it degenerates the neurons. It affects the brain, kills parts of the brain. Chronic decline in intellectual abilities, memory, abstract thinking, judgment. And another highlighted point, loss of cholinergic neurons, important for memory and learning. And so the acetylcholine is going to match up with cholinergic neurons. That's what they're going to bind to. And if you're losing those neurons, then that's going to affect the acetylcholine. Glutamate is increased in amounts because of this imbalance. So if you don't have if you lose the ability to utilize the acetylcholine, then the glutamate is going to increase. So increased amounts can cause brain cell death. Another thing that happens is people who have Alzheimer's develop something that they call plaques and tangles. They're amyloid plaques and these protein tangles that literally choke off the brain and kill parts of the brain. And this, I think there's a video in here. It's an NIH article, but hold on, let me see. I think there's a good video in here about Alzheimer's. Didn't check the link, so it could not work, but let's try it. Okay, this is actually not the video. It was lovely, and I didn't really want to turn it off, but because it actually had some good, I liked how it said, like brushing teeth. That was good. But what I was looking for was the one this one. Okay, sorry. We're gonna watch this one now. Because this one actually shows the plaques and tangles. I don't know if I'll play the whole thing. Okay. Think I would watch the rest of it if you want to, but that was the main point that I wanted you to see was that part about the plaques and tangles, because I think I liked the animation a lot and I liked how they explained it. So I thought that was handy dandy, but that's in the PowerPoint, so you can go back to that. And sorry, I have to find okay. All right. So for Alzheimer's treatment, then, to try and deal with some of that stuff. So some people that have Alzheimer's, they're going to be on other medications. They might be on anti-anxiety medications. They might be on cardiovascular or diabetic medications because, there could be stuff like they've had arteriosclerosis, or they could have been diabetic for a long time. So they might have these other drug therapies, but specifically um, for treating those plaques and tangles and things associated with Alzheimer's, they want to try to prevent the destruction of the cholinergic neurons. So that's the problem, and because there's less acetylcholine being produced. So they want to try to control the destruction of that, keep it around longer. So the drug that they're going to try and develop to counteract the Alzheimer's is going to try to deal with that problem. So if we were a drug, basically, would you want to be an like a acetylcholine agonist or acetylcholine antagonist? You'd want to be an agonist, something that would like try to keep the acetylcholine around. And then if we're thinking of things like the destruction of the cholinergic enzymes, whatever is destroying them, I think it's some kind of an enzymatic process, but you would want to try to prevent that process, right? Because therefore, then there would be more receptors for acetylcholine to be involved with. Oops, did I have another? I guess not. I thought there was something else to that slide. Okay, so there's no overall cure yet for Alzheimer's. They do have blood tests and genetic testing. You can do different things. They say, which is horrifying, but they say some of the mechanisms can start as soon as like 20 years prior to any kind of clinical symptoms. So somebody could have, like my age easily could have some things brewing that wouldn't show up until I was 65. And so you can do some pre-screening for that, and some people have, but there is currently no cure, no current drugs to stop the plaques and tangles from developing. They do have some different mechanisms, but mostly the current drug therapy targets at slowing the progression of the cognitive decline. So it increases cholinergic activity. And this cholinerase inhibitors, they're basically, that cholinerase is like enzymes that would break down those cholinergic neurons. So it's trying to like prevent the breakdown. So that's the cholinerase inhibitors. And then these NMDA antagonists, they help to reduce early neuron death as well. So help protect the neurons. Symptomatic treatment, again, anti-anxiety, behavioral things. So those aren't really going to do anything with their specific Alzheimer's disease. It's just going to be more like treatment to help the patient be less anxious, happy, less combative, things like that. And then cardiovascular metabolic risk, they probably have they could potentially have diabetes, prediabetes, or some kind of cardiovascular disease as well. A lot of those go together. And then, so the mechanism of the drug is to decrease the breakdown of acetylcholine. So stop it from breaking down in the synapse by inhibiting this enzyme, inhibiting the acetylcholinesterase enzyme, and then allow for more acetylcholine to be available. So the agents, Aricept, donepezil, or I said it wrong, donepezil, and then razidine or galantamine. So those are the two in red. There's this third one in the middle that you don't have to memorize, but these two. And some dental implications for a lot of these drugs are dizziness. They can make the patient dizzy. So if you already have an older patient in your chair, you're already wanting to raise them up slowly. You don't want them to have that orthostatic hypotension. Their blood just takes a little bit longer to sort of equalize, and sometimes they don't get the blood flow back to their head as fast, so they can get lightheaded. So that's already a concern with an older patient, but if they're taking a medication for Alzheimer's, they could have an even bigger side effect of being dizzy. So they are definitely more of a fall risk. And then there can be quite a bit of nausea and vomiting. So that could affect their teeth. They could have, if they're taking the pill and it's giving them that side effect, they could have erosion, especially if it's happening a lot, if they're vomiting, a fair amount on a regular basis, and they have to be on that medication. They might not take them off of it. They might just try to do something to counter it, like have them rinse their mouth with baking soda afterwards, or use extra fluoride, something to help kind of counteract the erosion from the acid in the vomit. So those are some things that you could contend with those medications. You do not need to memorize this little figure over here. I just like adding these for those of you who like to dive in a little deeper and see the mechanism of how it actually acts. The next medication was the NMDA antagonist, so kind of protective to the neurons. The mechanism of action Release of excessive amounts of glutamate are thought to be involved with programmed cell death. So it's that excitatory, a little bit is good, too much can kill the neurons. And so, and then NMDA is the N-methyl D-aspartate, the receptor antagonist. So it blocks the effects of glutamate. So if there is excessive glutamate, this medication is going to block it so that it can't overexcite the neurons that are there. So it's going to block the effects of glutamate. And then let's see, memantine and Namenda is the medication for that one. And this can also make the patient dizzy. So dizziness is another side effect. Okay, so that's Parkinson or Alzheimer's. So what the take-home points that you really want to try to think about with that is how acetylcholine is involved. So we're reducing, the acetylcholine is being reduced, the glutamate is being increased. So the drugs that are involved are going to try to help acetylcholine stick around and reduce glutamate. That's like some major take-home points that you want to walk away from after you review this stuff for Alzheimer's. Because when we talk about Parkinson's, it's going to talk about acetylcholine again, but in a different function. So this is all learning and memory, and then Parkinson's, it's going to be different. I feel like there was another slide. Do I have it hidden? Oh, it's the one that says like the mild, moderate. Is that the one?
In Alzheimer's disease, risks of oral disease.
Well, I guess I hit it. I hit it on myself. I thought maybe I took that. Maybe I hit it because I took the question out. I asked a question about in years past, the progression of Alzheimer's, and because I wanted you to think about, mild versus moderate versus severe. Obviously, a patient that has severe Alzheimer's is going to be, have a lot of care given. Like somebody's going to do a lot of stuff. They're going to probably brush their teeth for them. But when somebody's in early to moderate stages, they might still come into the office. You might see them on a regular basis. So you just want to think about, how am I going to have to talk to this patient? How do I help this patient? What are some tricks I can do to help them remember to, do oral care? And I thought I had the slide in there, but I think people maybe historically didn't. Is that one hit? That's a different one that's hidden? Ooh, okay. That's the one that was the slide I was thinking of, but okay. And if it's like Tanya can see the hidden ones, if you have that too, feel free to look at those slides. I usually hide them on purpose because they're not going to be content on the exam. And I know for a fact that mild, moderate, severe one, if anyone else can see that was content that people didn't typically do well on. So I finally just took it out. And so that's why I've hidden it. So it's not that it's not good information to have. I just am not going to put it on the exam. Okay, so Parkinson's disease is the next one. So age-related condition. It is chronic and it's progressive, just like Alzheimer's. Alzheimer's isn't going anywhere. It's a chronic condition and it's progressive. But this one is degenerative disorder of the central nervous system. So it's a kind of, go back to the definition, or I don't know that it's an official definition, but it's just, the PowerPoint definition of those two conditions, just so that you can really know the difference because they're both highlighted in yellow, so they're probably going to be on the exam in some way. So you want to make sure you know if I'm asking you about a disease, which is which. Okay, so for Parkinson's disease, the main neurotransmitter imbalance is between dopamine and acetylcholine. So the dopaminergic neurons and the acetylcholine neurons. So if the patient has a loss of these neurons in the substantia nigra, which is an area of the brain, and I'll show you a picture of it here in a minute, but they lose those neurons, and so they have like a decreased amount of dopamine. Now, interestingly enough, when we learn about the psychological conditions, we'll learn about schizophrenia. So if you have not enough dopamine, you're going to see strange, uncontrolled body movements. If you have excessive dopamine, you can hallucinate. So people with schizophrenia who are schizophrenic, they oftentimes have excessive dopamine. And so they'll give them medications to reduce that. And then they can end up with Parkinsonian condition. It's like Parkinson's disease, but it's not really Parkinson's, but it's because they've reduced the dopamine in the brain. So they're kind of like opposite ends of different ends of the spectrum. So imbalance of excess acetylcholine and reduced dopamine results in motor dysfunction. So now instead of like with Alzheimer's, we had not enough acetylcholine. Now we have excess acetylcholine and it's going to affect motor dysfunction. So with somebody with Parkinson's disease, we have this, what do you call that thing? When we have the first letter, we call it TRAP, and each letter stands for something. I can't remember what we call that. An anagram? Acronym. Thank you. So it's called something and somebody here knows it. So clinical symptoms, we refer to it as TRAP, and it stands for tremors, rigidity. So somebody with Parkinson's kind of has this shuffle walk. They're very rigid. And then akinesia or bradykinesia, that's like movement, slow movement, and then postural instability, so poor balance. So stands for TRAP. The other things that we see is this shuffled walk. Remember when President Biden was in office and people would accuse him, like everyone thought that he had Parkinson's, or some people thought he had Parkinson's, which I don't know if he actually did or not. But the one main reason why they would say that is because when he walked, he kind of shuffled. And you could just see that if you looked at like a video of him walking across the grass or something like that. But that was the main reason why they said that. I don't know if it was true or not, but it was reported. But he had like a kind of a short shuffled walk. And then the other thing that you can oftentimes see is they'll refer to it as mask face. And that's basically like your face just does. It's like you could call it Botox face. Your face just doesn't move very much. It's just very frozen. So it's just kind of a frozen. And so those are some other characteristics of Parkinson's disease. Okay, so there's a couple systems in the body. We do not go into any kind of big depth. I don't honestly even remember if there's a question on the exam, but I would still probably try to, keep this slide in your study. But there's two major systems in the body that sort of are affected when somebody has Parkinson's disease. Our muscle movement is initiated out of the pyramidal system in the body. We're not going to go into great depths about what that system is and how it works and blah, blah, blah. That's just a memorization point. And then, but the muscle movement is controlled. So like we initiate some movement, but then the control of something. And toothbrushing is a perfect example of this. You might initiate toothbrush movement, but then you have to continue this small, finer motor skill. So the movement is controlled by the extrapyramidal system. And so this is a part that's significantly affected in Parkinson's. So there is, because of this decrease in dopamine, there's an increased inability to control movements out of this system where these things are initiated in the body. And Michael J. Fox, this video I won't play, but just because I'm not sure how we're going to do on time, but I would watch this one too. It's really, and he has gone considerably downhill. He's amazing because he was diagnosed with Parkinson's when he was pretty young, and it's been very slow progressing. And he's had it for decades. And I saw a recent video of him not too long ago, and he looked pretty bad, but he's still out there functioning and stuff. But in this video, he talks about how hard it is to brush his teeth. And so I would, and he said something funny because he has the most amazing outlook on life. He said something about like he has to like hold his arm still and he just lets his body like move around his toothbrush. I mean, he has like a sense, I don't know how you have a sense of humor, but the other thing he was saying that was so fascinating is that he at this stage when they recorded this, he was being interviewed by somebody on like CNN or 60 Minutes or something like that. And he was still like playing, he loved ice hockey. And so things like that, where he's like doing like big movements, like the minute he starts doing it, his movements were smoother and more controlled, like bigger movements, like playing ice hockey. But things like toothbrushing was harder. So he talks a little bit about just living with the disease. And this was probably, I'm sure this was at least 10 years ago. So he has gone, it's progressed, but pretty interesting story. So, okay, so the treatment for Parkinson's disease. So again, we have this kind of overall problem statement. The problem is this imbalance between dopamine and acetylcholine. And so the objective, if we have not enough dopamine and we're having excess acetylcholine, you can imagine what the drugs are going to try to do, right? They're going to try to increase dopamine and then control the amount of acetylcholine. So we have several different drug categories for Parkinson's. So the first one is it targets, so it's meant to increase dopamine effects. Now, dopamine, like you can't just take a dopamine pill and have it cross the blood-brain barrier and have it just do what you want dopamine to do. So you got to be a little bit more like sneaky than that. So there's a dopamine precursor called levodopa, and that's always given with another one called carbidopa. So that's one of the main drugs that of all the drugs that you have to memorize for Parkinson's disease, you absolutely should know levodopa carbidopa. Like that's definitely going to be asked on an exam, and you should definitely know that. So it's a dopamine precursor, and it's always given along with carbidopa because it keeps it from breaking down, I think, once it crosses the blood-brain barrier. So levodopa is one of them. And then there's dopamine agonists. So a dopamine agonist, it reduces oh wait, no, we're still talking about levodopa. Sorry. Okay, I confused myself. So so once it crosses the blood-brain barrier, it acts like dopamine, or it like stimulates dopamine production in the brain. And then okay, now I'm confused about my slide. Sorry. Are these the different categories? Hold on, let me look ahead. Oh, it is separate. Okay, those are the categories of drugs. I'm like, what did I even write? Okay, these are the different categories. Okay, I'm sorry. So there's the precursor, there's the agonist, and then there's the ones that would try to keep dopamine around. So those are all just different categories. And then we're going to talk about the different ones. And then there's the drugs that block excessive acetylcholine, or the anticholinergic drugs. Okay, so I jumped ahead of myself. I think that's why I confused myself. So levodopa, carbidopa, they're always given together. Levodopa, it's converted to dopamine once it crosses. So it's hard to get it into the brain. It's hard for it to cross the blood-brain barrier. And so you have to get it across there, and then you want it to function like dopamine once it's across the blood-brain barrier and not get broken down too early before it can be beneficial. So that's why they attach the carbidopa to it. Prevents breakdown of the levodopa in the peripheral circulation. So some dental considerations or some side effects. Xerostomia, so dry mouth, taste alteration. Dysphagia is like a weakness or an inability or difficulty to swallow. And then orthostatic hypotension. So dizziness, if you're your patient up too fast, lightheaded, dizziness. And this flow chart, it's a little bit confusing. Again, you don't have to memorize it at all, but it kind of shows some of the drugs and some of the mechanism of action. Sometimes this just is more confusing to people. Sometimes they look at it and they like kind of figuring out the flow of the meds. Okay, so that one is the precursor. Okay, so the next one is the agonist. Okay, so these are dopamine agonists. I will tell you that there is an exam question that asks about Mirapex and Requip, and it asks about the category, and the correct answer is that it's an agonist. And historically, people mark it wrong. I think they end up they get this one confused with the levodopa carbidopa. So a medication that's mechanism of action is to mimic the effects of dopamine in the brain. That's a dopamine agonist. So it kind of is a weird, tricky thing because you're thinking, well, if it's an agonist, isn't it making dopamine? Where the mechanism of action is, it says it mimics the effects of dopamine. And we don't have to go into the deep chemistry, pharmacological reasons for that. But I know that just from what I've heard pharmacists talk about it, it's hard to get things into the brain to act on the brain and work in the brain. And so whatever the mechanism of action, it's not that it's specifically dopamine, but it's mimicking the effect. So it's doing what it needs to do, however they design the drug to work. So agents that are dopamine agonists that mimic the effects of dopamine are this Mirapex and Requip. And those are two pretty common drugs for Parkinson's disease. Dental considerations, dry mouth, dysphagia, orthostatic hypotension, pretty similar to the levodopa carbidopa. Okay, now we have drugs that work to decrease the breakdown of dopamine or levodopa. So they're trying to keep the dopamine that's already there, trying to keep it around. So they call it an MAOB inhibitor. It has something to do with the receptors. And then we have these two drugs, but the only one you have to remember is the one in red. So Eldepril or whatever this one is, selegaline. And then the dental implications are pretty much dry mouth across the board. So this is a pretty easy category. A lot of the medications in the next week, the like anxiety, antidepressant, all of those drugs, anti-seizure meds, a lot of those drugs all cause xerostomia. So it's a pretty, across the board, that's a pretty common side effect. Decreased salivation contributes to dental disease. We know that. Okay, and then the last one, COMT inhibitor. Again, just another flow of, the enzymes and the receptors. And so it's trying to inhibit this area here of the dopamine breakdown. And so Comtan is the name of the medication, always given with levodopa carbidopa. There's usually multiple medications that somebody with Parkinson's will be given. Dental implications, xerostomia, altered taste, and orthostatic hypotension. So I asked, this was a question on the last exam, the anticholinergic agents, and it's just going to come up again. It's probably something that you'd even be asked on the national board just because it so directly affects saliva, which affects dental health. So it's a very popular pharmaceutical type question to be asked on the national board. So you just want to know from here on out that any medication that's anticholinergic will produce the SLUD, decrease in salivation, lacrimation, urination, defecation. And there's lots of medications that can cause dry mouth, but anticholinergic specifically are the ones related to that SLUD, the acronym SLUD. So an anticholinergic agent is gonna, its mechanism of action is block excess acetylcholine because we have not enough dopamine, too much acetylcholine. It's useful also for the tremors and the rigidity, but not for the slow movement. So it kind of affects movement in the way of helping with the tremors and the rigidity. And then the drug would be cogentin. or benztropine. And then again, dry mouth is the main one, and that dental considerations so it could they person could have dry eyes and they could have the other things too, but our main consideration is the dry mouth. So so we'll stop there. We'll take a little break from that point on. But just when you're studying this, you'll get just as many questions about the conditions, Alzheimer's and Parkinson's, and how those neurotransmitters play a role, as much as the medications. There might even be more questions about those than the actual medications. But you'll only be tested on the medications that are in red for this unit. So try to just think of them in terms of categories like requip, and just think of the category, instead of worrying too much about the mechanism of action. Although I would still say flashcards, put it on one side, put the mechanism of action on one side and the name of the drug on the other. Because I know this stuff is hard to study for. Okay, so we'll stop there for we'll do 10 minutes. Okay. So we're gonna go on to epilepsy and seizure disorders. So there's actually not a lot of drugs. The harder part of all the drug memorization for this week we already did it. So there's a few more drugs. But there's a little bit more content in like the functionality of different seizures. And then a little bit at the end for the neuropathic pain. But the bulk of what you have to kind of learn from this unit, we already went through actually. So there's not too much more. Okay, so for epilepsy and seizures are a group of disorders characterized, or epilepsy specifically, I suppose, is a group of disorders characterized by seizures. Could be just an alteration of consciousness and awareness. Somebody might completely become unconscious, or they might just sort of zone out a little bit. And then involuntary movements caused by abnormal electrical activity in the brain. Sometimes they have a lot of trouble diagnosing and treating seizures. There's lots of different things that people use outside of medication. I know that I've had a good friend whose husband has epilepsy, and so he used medical marijuana, and I think that's been pretty well documented that it actually makes a difference. And then there's some other kind of alternative therapies that people can use. And some people have had like little implants put in their brain to like kind of do something with the electrical activity. So it's kind of an interesting, that was the other thing. I had a patient one time when I was seeing patients in my mobile practice. I had a younger girl come in. She said that she had, I don't remember if it was epilepsy or if it was just a seizure disorder. I can't remember, but she had very, very frequent seizures. And then she went on like that keto diet. Like she went into ketoacidosis or whatever the thing is where you go into that ketones, or I don't know, I've never done it before, but it's where you eat all the protein. And the minute she got into that phase and then she stayed there, she didn't have seizures. And so that's been studied as another kind of alternative therapy for people who have seizures. And it's been documented to actually, for some reason, it does have a beneficial effect. But I thought that was pretty wild. Okay, so I totally got off course. Here's the next bullet point. So may occur in partial, or they're called like focal seizures. So that's just part of the brain's being affected, or generalized if the whole brain is being affected. Prevalence, about 10% of the population could have at least one seizure in their lifetime. Seizures can be from like, someone could have like a tumor growing or something like that. And it could cause a seizure. So there's different things during different times where it could someone could have a seizure. Very more common in childhood, and then a lot of times if kids do have a seizure for whatever reason, they could outgrow it, kind of like asthma. Sometimes kids will have asthma when they're young, but they'll kind of outgrow it. So this is just sort of breaking down the different types of seizures. So start this because there's some information that you'll want to know for the exam. But again, a partial or a focal seizure is just affects only part of the brain. It could be simple, so it could be just a very sort of zoning out. You might not even entirely know that the person is having a seizure. Could be very subtle, just sort of like their awareness is still mostly intact, but maybe there's just something slightly shifted. You might have to be pretty aware of what's happening in order to know that they're even having a seizure. And then it could be more complex, which could actually impair their awareness. They might not respond, and so then you would know that they're actually having a seizure. Variable presentation may have autonomic symptoms, abnormal sensation, hallucinations. So it could present in different ways. But again, it's just a small part of the brain where it's happening. It's not like the whole brain. And then there's clinical generalized, which affects the whole brain. But again, it's kind of broken up into these different sort of segments or different specific symptoms. So an absence is when the consciousness is impaired, when they're kind of like either went unconscious or just sort of went blank, like they're just not there. Staring, they're not blinking. So that would be a cognitive or a consciousness thing if they're having an absence seizure. And then atonic is abrupt loss of muscular tone and loss of conscious, sudden collapse. So sometimes the seizure will happen in phases where they'll kind of go through these different effects. And then there's myoclonic, which is a sudden jerking of the arms and legs. And again, the person is usually unconscious at this point. And then there's the tonic-clonic, which a lot of people sort of think of when they think of a seizure because they think of like the jerking or the rhythmic moving. And that's kind of what comes to mind when you think of someone having a seizure is just like flopping around and not being able to control body movement. Again, loss of consciousness, repetitive jerking, sustained stiffness, post-seizure amnesia, possibly cyanotic. So maybe their lips turn blue. They maybe didn't get enough oxygen during the seizure. And then there can also be unclassified seizures, such as the status epilepticus, that medical emergency where they're seizing for like a long time. Usually a seizure is pretty short-lived. But if it keeps going, then the person has to go to the hospital. They have to intervene somehow with medication that they have at the hospital, or they might need some breathing support, or physically, they're going to need more support. A lot of times if somebody has a big seizure, they'll have that first sort of like clenching of everything, and they might have like they call it like the epileptic cry because like everything like kind of seizes and tightens and air gets pushed out of the diaphragm, and then they go into that tonic-clonic, like the jerking movement. Medical complications of seizures, aspiration pneumonia, or just aspiration in general. If someone was eating or they had gum in their mouth or cough drop or something, and then they had a seizure, they could aspirate. But just aspirate the bacteria in their mouth. So if they have a highly diseased mouth, they have caries or perio, and they just have a lot of bacteria in their saliva and they aspirate it, they could get aspiration pneumonia. There's lots of dental complications, such as having caries because of some of the medications. Trauma is, of course, big. Lacerations from hitting their face, biting the tongue, biting cheeks, getting, their frenum or something could get torn. I mean, you just think of all the different things that could happen if they all of a sudden fell or hit their face on like the side of a table or something. And then there's medication-induced gingival hypoplasia. If you don't walk away from school knowing this, you've learned nothing. So this is like the thing that this medication has been around forever. It's caused gingival hypoplasia forever. It's been around for decades, the phenytoin, and it's just like a very commonly asked question on the national board. So it's just one of those things where of all the medications, you should just keep this one at the top of your list of things to memorize. And we'll go over phenytoin and it might be the next slide, I think. or two slides down. But medication can cause the hyperplasia. There can be excessive bleeding and delayed healing depending on the medications. So these are the three meds. They're not in red, but I do want you to know that these go in the category. I should have turned them red before. I should have turned them red and saved it. But these are the meds that you should know go in this category in the seizure. And they all have some kind of like side effect oral consideration. So the Depakote, I don't know what that one is, but so it's put in this nice little table that I made that has the drug, the mechanism of action, the side effects that are sort of connected to what we would want to know, and then more dental concerns. So the mechanism of action for Depakote, it affects the sodium and the potassium channels and reduction in aspartate levels. Aspartate's another neurotransmitter, or an increase in the inhibitory neurotransmitter, GABA. So you don't need to know specifically, but I just would try to memorize at least that Depakote has an effect on sodium and potassium channels. And that kind of would probably be enough to trigger, your memory about what it is. And then there's some side effects with the GI system, very sedating. A lot of these medications can make people feel kind of sleepy, but this one in particular, and it can also have an effect on bleeding, which is important for us to know as hygienists. So a major dental concern, additive bleeding risk, use caution if they're on other things like Plavix or warfarin or anything, or taking aspirin. So if they're taking Depakote along with something else, you just know that they could have a higher risk for bleeding. So pretty impactful on our end. And then Tegretol is the next one, another anti-seizure medication. This one blocks just sodium channels, stops the propagation of the nerve impulse. So no potassium here, just sodium. It side effects, central nervous system depression, so sedation. It's probably very relaxing, sedating. GI, dry mouth, glossitis, inflammation of the tongue, and stomatitis, just sort of inflammation in the mouth. So those are some pretty impactful oral side effects. Used to treat trigeminal neuralgia. I don't know that we talk very much about trigeminal neuralgia in this class, but in special needs, we bring it back up. And so this could be a medication. Trigeminal neuralgia is it's pain, the trigeminal nerve. There's a lot of pain in that nerve area, and it's very difficult to treat. But one way that they might treat it is with this anti-seizure med. So sometimes, they'll use drugs off-label. Again, there's more of a bleeding risk for Tegretol. And then the big daddy, phenytoin, dilantin, you got to know that one. You just have to. And so that one blocks the sustained high frequency repetitive firing action potential in the brain. So it kind of like has a very soothing effect on the brain, just keeps it from like overfiring or, being overstimulated. And so, but it does have a big CNS sort of suppressant. So kind of, again, that sedating thing. It can interfere with vitamin D and folate, which is kind of a big deal because those are really important for almost every cell in our body has a receptor for vitamin D. So vitamin D deficiency can have a lot of downstream negative effects. So somebody who's on this should probably take supplement. Folate interference, teratogenic effects. So shouldn't take it if you're wanting to get pregnant. And then gingival enlargement is the big thing. So here's like just a you guys have seen it, I'm sure, by now in other classes. So that's a good example of gingival hyperplasia. And because I anticipated somebody was going to ask me why it happened, why it happens, I put in the notes the main reason of what causes it. So one thing that I always learned in school was it affects the fibroblasts. It stimulates fibroblast production and the collagen and reduces the breakdown of the collagen. And so it just kind of encourages tissue growth. However, what we always learned is if the patient has really good oral hygiene, they can suppress it. So if somebody is really fastidious, really particular, really good about keeping their oral hygiene, they can prevent a lot of it. It still might happen to some degree, but the bacteria in the mouth exacerbates it. So it makes it even worse. So the drug itself is having an effect on fibroblasts and collagen breakdown. So that's part of it. But oral hygiene is another big part of it. So if their oral hygiene is really good, they can sort of counteract it a little bit. Okay, so it depends on the drug levels. Higher drug doses are going to give more gingival hyperplasia. Dental consideration, it can occur within the first 6 months. Again, the oral hygiene, the professional cleaning, just staying on top of it can really help. They can cut away the excess tissue. It could grow right back. So if somebody's like been on phenytoin for just years and years and years, this might be something that they contend with all the time. So and then xerostomia. They have started prescribing other drugs, but that used to be like the gold standard, the only one. But these, like the Tegretol and the Depakote, those are newer drugs and I think they're pretty widely used now. And they don't have that gingival hypoplasia. Okay, so just a little bit more about the drugs. So back to the Tegretol. It can cause xerostomia, glossitis, severe blood disorder of aplastic anemia, and some other side effects here. It can increase risk in combination with NSAIDs. So caution with if somebody's taking ibuprofen or Advil or some other NSAID. And then the Depakote, just reviewing the dental considerations again, xerostomia, glossitis, increased bleeding, and periodontal abscess and gingival hypoplasia are a side effect, just not as common for this drug. So that, guess that's it. Okay, so then the last section, neuropathic pain. So what is neuropathic pain? It's basically just nerve pain. So that's like trigeminal neuralgia is basically like nerve pain. So it's a type of a neuropathic pain. It's in the peripheral neuropathy, peripheral neuropathy is one thing that people can experience if they have diabetes. And remember, if you remember from several weeks ago when we talked about diabetes, how it can negatively impact small blood vessels and larger blood vessels, but also the peripheral nerves. And so diabetic neuropathy is something that people can have. So that's a major cause of, how did that get advanced? Did I do that? I didn't think I did that. Just jumped ahead. But so that's a major cause of neuropathic pain. Could be somebody with like chronic diabetes, long-term diabetes, but also alcoholism. There's other reasons why somebody might have it. They're down here, fibromyalgia, shingles. So there's other reasons why people might get neuropathic. Yeah.
I think if you're telling a patient where they know they're taking the phenytoin for it, do you say to them like the only reason, it's the only way to get rid of it is to stop taking it? Is there anything else that can stop?
That is oral hygiene and not taking the medication is pretty much their choices. So a lot of times, I've only seen a handful of people that had it in my whole career. So, even if I've seen patients on phenytoin that didn't really have it. And then I have seen people who had quite a bit of hypoplasia. So it is one of those things where that drug and their treatment with their doctor sort of trumps the dentist. So they might just have to live with it. So a lot of times, like I can think back to one patient, they came in more often. I saw them, I'm pretty sure I saw them at like every 3 to 4 months. And then I just try to get them to work on their oral hygiene. And then I can't remember if it gets bad enough, if it grows down close to the incisal edge and the occlusal surface, they can have like it cut away, like with a laser or like a scalpel, but it's probably going to come back at some point. But some people choose to do that. But yeah, that is kind of the options. Like if there is another drug option, they might do that, but just work on oral hygiene and come in maybe more frequently. So it is kind of just box them in if they have to take anti-seizure medication. Okay, so the type of chronic pain that occurs when the nerve in the central nervous system becomes injured or damaged, and um, and then it can also be damaged nerve in the periphery as well. But it's a harder pain to treat because, you know, if you have, and we talk about this a little bit more in the pain unit, the managing pain, but if you have a cut or you have a surgery on your leg and you have like a burn or something like that, like you have an injury, it's easier to treat pain that is coming from like an injury that's very specific like that. It's harder to treat nerve pain. Especially if it's from some kind of a chronic condition like fibromyalgia, diabetes, things like that. But they have these medications, gabapentin, and then pregabalin or like Lyrica. Those are different medications. Gabapentin is a very popular. Dentists have historically prescribed gabapentin for different reasons to patients. And sometimes they can prescribe them in very large amounts, and that's a little bit controversial. Um, but, and like my grandpa was on it. He had dementia and he took a large dose of gabapentin. It's very soothing also, like people can take it for anxiety. It's kind of just like a calming medication, but it also has a positive effect on neuropathic pain. Um, so somebody might take it for migraines. They might take it for trigeminal neuralgia again. And this is just showing the areas of the face where trigeminal neuralgia the pain can be located, and different types of migraines. Okay, so for gabapentin, the mechanism of action, GABA reduces the excitability of nerves. So GABA is kind of a soothing, calming neurotransmitter in the brain, which plays a role in seizures. So someone might also take gabapentin if they have seizures. But it also plays a role in the transmission of the pain signal. So it kind of soothes those neurons, it kind of quiets them, and then those pain signals don't get bounced around as much. So you have less of an awareness of the pain. Um, Gabapentin can be given in very large doses, multiple times a day. There's many other uses. When I had LASIK done, you know, like the laser for your eyes, and they gave me gabapentin for an anti-anxiety med. I did not take it, but I could have. I was just like, really? I was more used to like, you know, like Xanax or something like that. But that's what the doctor prescribed was gabapentin. So they can use it for anxiety, seizures, restless leg syndrome. So where your legs like kicking at night. And then dental considerations, xerostomia, dizziness. So that's Neurontin or gabapentin. And then pregabalin or Lyrica, the mechanism of action inhibits calcium influx, subsequent release of excitatory neurotransmitter, and it calms the nerve. So this calcium influx, this incoming calcium into the neuron has an effect and calms the neurons. So again, pregabalin and other things, anxiety, seizures, epilepsy, along with neuropathic pain. It can cause dry mouth, dizziness. It can be very sedating. Thrombocytopenia is a blood disorder. And so it can increase bleeding risk. So that's, again, something to be aware of if someone's taking aspirin or any of these other drugs, antiplatelet, anticoagulant drugs. So here's just another sort of, I got it going for you. It's just another way to test yourself. That's all I can say is about this. Just practice trying to like give yourself the opportunity to see what you remember. So like this is just another example. You put the drug and the dental implications, the category, and then try to remember the drugs that are in those without, you know, looking back and then seeing if you got it. And then mix it up a different way. Write the drug and then try to remember the category it came from. So if you do that, that will be something to kind of help you remember these long, complicated words that don't mean anything to us unless you know somebody who took the med. And then you're like, oh yeah, you know, it's easy when you have some kind of thing that you can relate to it, but otherwise it can be quite challenging. But all right, so that is it. I hope you guys have a wonderful spring break. I'm here tomorrow, but some of you I won't see. Anyone else going to Arizona? I'm going to Arizona. Anybody else? No? I know. I'll be in 100 degrees weather.